Would you like to say who you are and why you're here?
Well, thank you very much for inviting us. I'm delighted to be here and I hope I can help. My name's Leslie Regan. I'm President of the Royal College of Obstetricians and Gynaecologists, which, as you know, is a membership society. We have 16,000 fellows and members, half of whom are working overseas. I'm also the head of the Department of Obstetrics and Gynaecology at Imperial College, based on the Mary's campus.
Great, thank you.
And I'm Linda Burke. I'm the Executive Director for Education and Quality at the Royal College of Obstetricians and Gynaecologists, and the guidelines work and the education work sits under my directorate.
Right, thanks very much indeed. So, as I was just saying, that you actually have put in very full evidence to us, written evidence, and thank you for that. And also your conflicts of interest, and that's what.
Yes, I was just going to ask, if I may, about the conflicts of interest statement. As Julia said, it's a very fulsome and comprehensive one, for which we're grateful. And obviously, it indicates that you receive funding from device manufacturers. I was wondering if you could outline for us what you think are the right rules of engagement, as it were, around receiving funding from industry. And I've got a quick follow-up question after that, if I may as well.
Do you mean as a college? Yeah. So we have historically been quite conservative, I suppose is the right word, about receiving funding from industry, etc. So we consider, in terms of the rules, what we aim to do is to make sure that if we do receive funds, that the organisation that's giving us funds is very, very clear about, if you like, the rules of engagement, and that we are absolutely clear that we are independent and that any funds will not influence any decision making or any guidance in any way, shape or form. So that's made very clear to any organisation if they give us any funding.
Well, I suppose it's challenging when if you come to the situation where you're reliant on funds for certain activities to maintain that balance. I presume. I don't know.
Do you want me to come back? Yeah.
So, for example, we do receive some bursaries for student prizes and competition prizes from Ethicon. They have no influence on the judging of these. They basically put the money into a pot and this supports activities, for example, at a congress.
But as a general principle, we haven't been in a position, certainly in recent years, where we have been reliant on funding. And again, just to emphasise, because largely we're a membership organisation, and in terms of exams, etc., that will always be the bulk of our funding, and that is actually the core funding that keeps the college going. So I suppose in some senses we don't have to rely on that kind of funding, and if ever there was a compromise, we would be in the fortunate position of being able to say no.
Okay, thank you. My follow-up question relates to your members and clinicians more widely. Do you think there should be a mandatory register, a Sunshine Payments Act type arrangement for clinicians in this country?
A mandatory
register of interests?
Well, my personal view is yes. And I think that we would support that as a college as well. You will have seen all over our submission to this review on this topic that we've been calling for a mandatory register of the procedures that I think we're going to talk about for some time now. One of the limitations that we have is we are effectively an advisory body, so we are responsible for the training and the education and the continuing professional development of these 16,000 fellows and members, but we don't have any regulatory powers. So I can advise individual clinicians or groups of clinicians or one of the 4 subspecialties in obstetrics and gynaecology, of which urogynecology is one, what we think that they should do. We can provide them with outlines of best practice in terms of clinical guidelines. We can provide them with all sorts of other tools to help them achieve best practice locally, but I don't have the clout to go in and mandate that it carries on with their individual healthcare provider. And for that I have to rely on going to the medical director or the chief executive of trust, or whoever is in charge of, or whoever is the senior responsible officer for that healthcare provision.
From the view of the patients who we've met going around the country, it's really helpful for them, it would be, if they knew what the conflicts of interest were for the different surgeons who were actually treating them. And there's good precedents for that. For instance, parliamentarians, we all have to put in our conflicts of interest, and it's updated every year so everybody knows where we're coming from, how we're being supported and so on.
So, for example, there are certain groups, so anybody who joins a committee, of which there are many at the college, fills in a declaration of interest, because I don't think necessarily a declaration of an interest is necessarily a conflict. Certainly all of the council members are quizzed on this, not just once, but every year. So the Board of Trustees, which I chaired this morning, it just happens to be that we've gone round and I'm asking them all to fill in a declaration of interest once again. So I think for the vast majority of individuals that we're working with and being an advisory body for, I don't think they would have a problem with that. I have to fill it in for Imperial, for the university. I have to fill it in for St Mary's Hospital Trust. I have to fit it in for an international organisation for women's health, which I've become Secretary General of, so I don't think that would be a problem.
So what needs to happen to make it happen?
It has to be mandated.
Mandated by?
Well, a regulator. Because I haven't got a regulatory function.
Well, I think what I'm getting at is, would your membership be resistant? If you propose this, do you think that they would actually all say, no, we're not doing that? Or that you could voluntarily ask them, would they do this? Have they been asked?
Well,
we ask them in the sense of, as Leslie's alluded to, in terms of college business, which is where we have power. We do ask them to do that. And I would also emphasise that in terms of the curriculum, for example, we very much make it part of the curriculum about transparency and being completely ethical in terms of how people behave, which would include this. But as Leslie's alluded to, we don't have the power, or it's their employer that has the power, or a regulator that has the power to make that. We could certainly propose as a voluntary system, but whether they would inevitably...
Shall we just leave it there?
Yeah, but in the same way that the GMC mandated that you had to state your subspecialty training interest. So I have beside my name obstetrician, gynaecologist, reproductive medicine. They could do the same. And I think that most people would be comfortable with doing that.
Great. Okay. Perhaps we could get on to the real subject for today. And I just want to ask, and I know, Leslie, that you haven't ever inserted mesh. It's not your part of your expertise.
That's my claim to fame.
But certainly your college colleagues, many of them would. But can I just ask you, from the research and things that the college has done, is mesh actually safe? Do we know how safe it is? Do we have any sort of evidence of that?
Well, I think the evidence is accumulating now, and we are, like you, very concerned about those patients who are telling us the problems that they've had. That's one of the reasons why, obviously, you're holding this review, and that I think we are at one with the Subspecialty Society, BSOG, and others in wanting to insist that training is mandated and very carefully regulated. And just for the use of mesh, if it's appropriate, also that we ensure that we provide really good informed consent, and the decision-making tools that we've been working on for some time now, and well before this review was convened, I think are an important tool as well. And now that there is a call for some patients wanting to have removal, I think it's important that the accreditation for removal centres becomes mandated as well. I thought it might be useful. This is Linda very kindly printed it out large. So this is the run-through training programme in our specialty. So this is FY1 and 2. That's your, if you like, your Houseman year, as it used to be known, and then you get a national training number, and we have a 7-year run-through training programme. So in these, so the core curriculum is delivered in those first 5 years, during which the trainee is expected to pick up their Part 1, their Part 2, and then finally their Part 3 MRCOG, usually aiming to get there by ST5 at the latest. So at that point, at the end of this core training, of which there isn't guideline, or there isn't an inclusion of MESH in that. So at no point would a trainee be involved in this. At the end of the 5th year of all the core training, you would differentiate into becoming a consultant gynaecologist after you've got to ST7 with a special interest in, or you would go and apply competitively, nationally, for a place to be a subspecialty trainee. And in our specialty, in obs and gynae, there are 4 subspecialty areas, of which urogynecology is one. So if you go in at the end of ST5 to go into generalist job with a special interest in, then you would be expected to take an ATSM. I think it's all in our submission, but I can happily send you a list of the acronyms. Advanced Training Skills Module, and there will be one for some urogynecology procedures. And you usually need to have 2 ATSMs before you can collect your CCST and go onto the GMC register as a registered consultant. If you go into subspecialty training here at the beginning of year 6, then you're involved in a much more intensive and much more carefully regulated training program. So the first subspecialty training program was started in 1991, I think I'm right in saying, at St George's. That was Stuart Stanton's big push there. And there are now 13 subspecialty training programs in urogynecology throughout the country. And the training program takes a minimum of 3 years. So they will do 2 years of clinical, if all goes to plan. They're visited by the college subspecialty training panels on site, and their competence is assessed in terms of numbers of procedures and skills levels attained at the end of each year. They do 2 years of clinical minimum, some of them have to do more, and they will also do a year of research in urogynecology. So it's a very detailed program. But I think it's just useful to know that of those, in those 13 centres, the first of which was in 91, there are now 13. You're churning out, or not churning out, but you're developing urogynecologists in a minimum of 3 years who will do subspecialty or really specialist work, of which this may be one aspect of it. And in total, we have 75 accredited subspecialists in urogynecology now in the UK. So there are a lot of, what my point is, I hope I'm making it clear that there will be a lot of other individuals who have done general training and developed an interest in, who are not going to have that same skill, degree of skills as them.
Well, that's very impressive. Thank you. Thinking about those who do insert MESH and the gynecologists and urologists and others, are you quite surprised that really we do feel that we get more complications than with other procedures? Has that come across your desk? Are you aware of that?
Well, you started your introduction to me saying I haven't put in a tape, and I haven't, but I did generalist training, and when I became a consultant and then specialised in reproductive medicine, the week before I'd run an operating list in Cambridge, where I did umpteen Colbert suspensions, so I did a lot of open surgery for surgical or for stress incontinence. And although informed consent wasn't as robust as it was then, I remember consenting women that there was a 10% complication risk with open surgical procedures. So I'm not sure that is something that people remember quite so robustly. So that there is a significant complication rate with open surgical urinary procedures as well.
Do you think that operation now, and I think we have a difficulty that a lot of people don't know how to do the suspension, and I'm just wondering, do you think that really is an alternative to MESH? Is that something we should be exploring as an issue?
Going back to this, which is why I use it, so if you were doing core training, you would only perhaps be trained or shown how to use MESH. Open surgery is very rare nowadays. eyes. And so I think there's a concern, and one of the reasons why I wanted to take, why we've not wanted to support an outright ban, but wanted to support the pause and the investigation in the review, is that I worry about those women who are unsuitable for procedures having nowhere else to go. Because colpoid suspension is a major surgical assault. And I also am concerned, as in an advisory and training capacity, that we've got a real gap in the training skills of these surgeons now. They just don't know how to do it. So although I don't do urogynecology anymore, you'll be relieved to hear, none of the trainees that I see on a regular basis have done a colpoid suspension or even seen them. They've become vanishingly rare. So I'm worried that we'll have a cohort of women for whom there is no relief from their quite debilitating urinary incontinence. And this panel will know very well how common that problem is.
I mean, we have obviously reinforced, we've very recently reviewed and had approved by the GMC a revised ATSM, and we're looking at our subspecialty training to actually try and build up, if you like, that expertise again. But obviously that does rely on there being people out there to be able to supervise and sign off. So it will take time in terms of that expertise growing out there in the community.
Because there was a view expressed that because MESH really got underway at quite some speed, and it was you just saw the figures mounting, that alternatives then were could have become better, could have had keyhole surgery as opposed to open operations as you've described. And it was described as colpoid suspension as being in a cul-de-sac, because it really wasn't. They had begun to develop it differently, but because of MESH that really took over, that all stopped. And I just wondered if there was an opportunity to regenerate that.
I think there is, and indeed there's a mentorship program starting for open and laparoscopic versions of the old procedures. But as Linda's alluding to, it's going to take time to build up, because always when you're training, you need a cohort of mentors for the learning curve and potential complications. And at the moment, what we haven't got are those mentors, except possibly in the subspecialty accredited centres, of which, as I said, there are 13.
And as Leslie's alluded to, in terms of the training, it's about mentorship, but it's also actually about a very strict sign-off procedure that people are actually competent to do this. So you need to be able to have observed and then carried out quite a number of these to be deemed to be competent at them. So we do have to make sure that we actually make sure that happens before we're actually creating a whole new cohort of people out there carrying out these procedures.
Because apart from the hierarchy that the NICE guidelines and things produce, a lot of women have said to us, well, where is the alternative? And so it's quite difficult that at the moment, but I appreciate what you're saying about having to build a cohort that has the expertise.
But if that is the recommendation from the review panel, then that, if you like, gives us a bit of armour to actually go and drive those mentorship programs and training programs.
Well, I'd like to tell you what's in the review, but we haven't written it yet, so we're still collecting all our evidence.
Yeah, I mean, just to pick up on that point, we heard from BSUD earlier, and BSUD talked about a retraining program for surgeons already in practice to refresh, as it were, skills around colpoid suspension, autologous slings. But I think they described it as being at the discretion of the surgeons. So, in other words, people could either take it or leave it.
Well, I think that goes back to, sorry to keep saying this, but I mean, we're not the regulator or the employer, but we as a college, have been responsive about other issues and are willing to be responsive in terms of training programs, and have worked very well with societies, etc., to develop those programs very quickly in other areas. So I think in terms of what's within our power, we're very willing to do that and to facilitate it. But in terms of the regulatory side of it, that isn't within our power.
But you'd be open to a greater impetus perhaps from us or from elsewhere?
Well, very much so.
I mean,
Because you know, we've been calling for a mandatory registry and for mandatory accreditation of all procedures, and now, as has become necessary, accrediting centres for removal.
And of course revalidation gives us a great vehicle, and we have a very good continual professional development framework that we can use, and is, without going into detail, extremely flexible in terms of how we can develop programs much more quickly than we could have done in the past.
Okay, thank you. Can I ask a question, a slightly different question about the procedure, one of the key procedures here that we're looking at, which is the TOT procedure for SUI. Our understanding, but I'd be interested to see what you think, is that it's conducted entirely blind, as in there's no camera and there's no imaging technology involved. Does that make it unusual in medicine and surgery?
Well, I don't like really to pontificate about things that I haven't got first-hand experience of, and I haven't put in a tape. I think a lot of procedures historically have been blind. I mean, it's only very recently that we managed to get the D's and C's taken off the list of advisory procedures, and that was always done blind. When I say blind, I don't mean that she had a blindfold on, but that she didn't have a camera to go in. And now I wouldn't dream of taking a biopsy from a woman's endometrium, i.e. a womb cavity and womb lining, without using a camera and you know, fibre optic instruments. So I think that I think possibly I would say it is unusual in this day and age that the vast majority of minimally invasive procedures are undertaken with the help of optics, particularly, and cameras. And recordings, of course. When I did my list on Monday morning at St Mary's, I record everything that I'm doing. So if there is a problem or a complication, we can go back into it. We've either got hard copy photographs, and in some cases, if you're anticipating potential complications, I would video what I was doing.
Is that quite commonplace in surgery?
I think it's commonplace. I think you'll find it relatively available in the majority of teaching hospitals.
So it depends on the availability of the technology, but also the discretion of the surgeon, or not?
So no, it's usually about the availability of expensive kit.
Yeah.
And you know, in talking about how you can mandate these things, it's going to have to be chief executives and medical directors or SROs that understand that if they don't impose certain modes of practice or criteria in practicing, criteria, that they will be responsible. And I suppose one of the ways you could do that would be that if the surgeon doesn't do things in a certain way, then if that trust isn't then reimbursed by whoever's funding them, and then then we get into all sorts of complexities about who's funding what and where the contracts are. But I think there are ways of mandating it.
One of the things that many women who we've met, and I think as Julia was saying, we've met many hundreds of women who've been adversely affected by mesh in many horrible ways. One of the things they often talk about is the lack of informed consent, that they didn't feel that the risks were properly explained to them, and in some cases not explained at all. But it raises questions around the risk-benefit of this procedure, and I just wondered if you had any thoughts on how to convey risk-benefit and how to ensure that a patient has a proper understanding of the risk and the benefit.
Well, I think explaining risk to an individual woman in my clinic, I think, is one of the most challenging things that I do. And I think as I've got more experience, I recognise that the challenges get bigger. I think it's one of these things, the more insight you have, the bigger you recognise the issue is. So Linda's appreciation of a risk of 1 in 100 of her having, I don't know, a baby with Down syndrome or having a complication as a result of a surgical procedure is very different to Victoria's appreciation of what 1 in 100 is. So for some women, risk of 1 in 100 is small, and for others it's absolutely unthinkable. So for some they dwell on, oh, it's 99 fine, and only one gets it. Others they think it's absolutely, So I think risk is very, very difficult. But there can be no doubt that informed consent and some of the decision aids that we've been trying to develop, not just for urogynecology, but for all sorts of other aspects of our specialty, which remember is probably the most contentious field in medicine, obstetrics and gynecology. We deal with almost every issue that's contentious, apart from assisted dying. And I think it's really important that we are leaders in that field and that we push for this. We will get pushback, though, from our administrative and our managerial staff, because if I was to take your female partner and give her, spend time with her explaining what a procedure I was going to do, ideally I would ask her to take away this paperwork, go and do her homework and come back again for another visit, and she might possibly need a third visit to finalise her decision. And most of our clinical directors are pushing us to get a 1-to-1 follow-up ratio from new patients to old. So again, there's wide areas of the system that are going to have to be brought on board to improve things like informed decision making if it's done properly in different stages.
I think the other thing to say, though, is one of the things that we have become aware of as a college is it's not just about the process and the paperwork, however good, it's about how the information is given. And that's some of the work we've really been pushing through the curriculum and through the training of doctors, not just ourselves, hopefully the other colleges as well, because it's actually making sure that doctors, as they're coming through and through their CPD, actually know how to give that information, and giving people the opportunity in all sorts of ways to ask the questions, to do the thinking time, and to feel they can ask a question and they can challenge. So that's something we have built in much, much more to training programs generally, is that whole how you give information and how you present the opportunity for people to actually think about risk in a different way.
So one of the other aspects of informed consent is being clear with the patient, the woman, that there are things you don't know.
Absolutely. Yeah.
And do you think that, in the case of MESH, one of those issues would be not really knowing the long-term, lifetime impact of having polypropylene inside your body?
And again,
should that be part of an informed consent conversation? And,
yes.
And has it been, in your experience, up until the pause, were people doing that?
Well, I think that was an individual. It was dependent on the individual and their if you like, their standards of what they consider best practice and standards of care.
But we absolutely encourage, and I'd go as far as to say prescribe through the curriculum that is how it should be done. And we have a number of working groups around different issues where we're actually saying that it's about being very clear about what you know, what you don't know, the risks that we have evidence for and the risks that we have yet to have evidence for. Medicine is changing very quickly. There are a number of those that we don't have evidence of.
We had a little debate with your colleagues earlier on about consent and about the quality of the clinical appointment that you have with your surgeon or your gynecologist or whatever. And one of the things that's come across very strongly from the patients to us is that they are convinced things weren't told to them, which may well have been told to them. And it's because you're so concerned about this particular event in your life, that you're going to meet this person who perhaps has inserted the mesh or whatever. So we were just wondering, with new technologies and things like that, whether in fact you could have an oral type recording, because most of us got iPhones and things, and then you would actually be able to take away that recording to your family or friends or whatever, so that you could discuss it. Because one of the colleagues here today, who actually is involved in cancer in this particular area, and he was saying to me that actually they don't take it in.
No.
All they want to know is, have I got cancer or have I not got cancer? And they don't hear the bit, you haven't got cancer, but what you have got is so-and-so. And so we're just wondering whether with the new world that we're going to embrace very shortly with new technologies and things, whether actually that's something that you might consider that would enhance the consultation that you have
Certainly.
with the,
I mean, you know, that thing about bring a friend when you're going to a
Yes.
difficult consultation is put in there for very good reasons. That you, as you rightly say, you have selective hearing,
Yes.
and you don't always digest things. Certainly, you know, when I run my stillbirth clinic, I always encourage people to bring someone along with them, and often on a second or a subsequent visit, I'll say, "Do you remember I was saying?" And they'll say no, and then the family member will say, "Oh yes, you did. Do you remember you said that?" Because so I think it's very valuable. So whatever way there is of being able, it's another way of conveying and explaining risk, and that's why I think it will be helpful if recommendations for staged informed consent were adopted widely. And that really does mean as well that the patient has to be prepared to do a bit of homework too. That you actually go along, you have your consultation. I could say, go and see Cyril Chandler, and I have a consultation, and he gives me documents for me to look at, to read, or it could be a video recording, or whatever you felt was most appropriate for that patient, and that they have to come back and almost like demonstrate that they've digested it all and understand what the risks are. But these are being straight. I mean, I don't need to tell you on the panel that incredibly time-consuming, which is fine for me, but I think we will have to find ways of persuading our masters, and particularly the contracts people, about how we're going to factor that in. But it's not a reason to shy away from it.
And increasingly, people who are coming through the systems will be used to that in training. You know, we use that role play, recording all the time. Because the other advantage, of course, is it improves your own practice because you can hear yourself giving information. So there's a lot of learning to be gained from doing that.
We have certainly heard stories from women where they've gone into consultations and they felt very as though their symptoms were not being listened to, and they were being very, very strongly dismissed, including one where a very eminent QC who spent his life asking questions in very difficult circumstances, that is his profession, accompanied his partner and didn't feel he could ask questions of the consultant. Now, if someone who's professional, whose whole professional identity is that surely is very concerning.
Yeah, I think there's another angle to this.
So what question are you asking?
Well, what I'm saying is, if the person, as you say, takes someone along to accompany you, if you are taking someone to accompany you who is a QC, whose absolute job it is to ask difficult questions in difficult circumstances, feels he cannot question the consultant because the consultant is giving the impression that this is my area of expertise, that surely is quite concerning, isn't it?
Well, I'd be horrified by it, yes.
But I think there's something as well about the consent tools where, and through, we've got a very good women's network, I'm sure we've talked about that in the evidence, but it's really about also working with patient groups, and that's something as a college I think we're seen as kind of very proactive in doing and want to continue to do in terms of how we really try to empower patients to feel, and women to feel that they can ask. So
and that's the critical point, isn't it? It's a power imbalance.
Exactly.
That's what they're feeling, and they just don't feel they can challenge that. And certainly for these very vulnerable women, as I say, the example that Sonia just mentioned is somebody who should not have felt that and did. So the question for these other women who are saying this to us, we now quite understand, is they obviously felt they could not say or question, and they weren't being listened to.
And that's, again, as I say, I'm repeating myself now, but we are really trying to get that across to trainees and through CPD with the doctors, but also in our role as a college, working with the public and working with women in terms of helping to make them feel they can ask those questions.
So in the, I mentioned that in the MRCOG, it's now got a part 3. And the part 3 is effectively how you respond and interact with patients. It's not really a knowledge-based thing. It's purely constructed around your interactions, and that's done with role-playing. There are lay members from the Women's Network sitting in all these OSCE interactive stations. One of the things that's been piloted is videoing people giving information and playing it back to them and demonstrating to them how they may have thought that they were listening and it was a two-way thing, but actually they were talking for 9/10 of the consultation. So it's a very useful way, and as Linda was just saying, you can get people, often when you show them how they performed, their opinion of what they did suddenly changes and they realise that actually they weren't listening.
I'm conscious of the time, and I've got one question burning to ask you, and Sonia has a question which she wants to ask you, which is related to your expertise, not as president, but in relation to hormone tests in pregnancy. So that's sort of giving you a warning what's coming. My question...
Oh dear, should I be frightened?
No, you shouldn't. No, it's just, I don't want this to end before we've got these two questions
Okay,
answered.
all right, yes.
The first one is relates to what the President of the Royal College of Surgeons has been writing about a database for introducing new technology. I have to say I strongly support his views. The notion is that you need to think of two things. One is a database, which is 100% accurate. And the other is the construction of a registry, which requires patient consent, and creating the database doesn't under GDPR. And the registry would then interrogate the database, which is a much more complicated procedure. It has extra costs, and it would take place in centres where they're introducing the technology, which would be funded to do that. But the question relates to the database. And the suggestion is that when the surgeon, and I'm not a surgeon, wasn't a surgeon, carries out an operation, they always fill in an operation note, at least always. Even I did for those little interventions I did. And the notion is that that is not a time-consuming affair, but it has to have, it would certainly have to have certain items filled in. One would be the name of the surgeon, the name of the patient, the NHS number, date of the operation, what was wrong with the patient, what the operation was. And if a device was inserted, it would probably be registered on that with a barcode. That's it. And that would be done centrally, probably by NHS Digital, though we haven't spoken to them about that yet. And that would then be the foundation of knowing, unlike ES, you've got 100% accuracy and collection. Would you favour that?
Very much so. We've been supporting mandatory registration in a database for a long time now.
Yes, but
The problem is the funding it.
Yes, but it's a very particular, the way of doing it, because it involves saying to surgeons, please will you make sure you complete that accurately and in all cases.
Yeah. But I don't think it's going to be, I think that if your review says that's what's got to happen, then the communication has to be with chief executives and medical directors.
No, I accept all that. But,
and I think it's possible to do.
Yes.
I mean, I always tell the story about how I've written several letters to the chief executive at St Mary's about a problem that I thought about, a patient safety issue, and couldn't get them to do anything about it. And then I was telephoned one morning as I was driving to work, at about 7:30, and I saw chief executive, I thought, oh right, this is great, they're going to sort this out. And she said to me, Leslie, I'm really sorry to bother you. She said, but you've come up on red on the trust thing because you haven't done your mandatory hand washing. And I have to tell you that if you haven't done it by lunchtime, you won't be able to operate. It's quite possible to do these things.
Quite what to say. There's a remark attributed to Charles
Which I didn't say, oh, I'll have the day off then. I
Yes,
said, oh
yes.
God, I better go and do my mandatory
Yes.
hand washing. So,
Well, there's a remark attributed to Charles I. There's more to doing than bidding it be done. There's more to the doing than mandating it to be done, to be honest. And if we were to suggest something, and the President of the Royal College of Surgeons or our COG said, well, that's nonsense, that's not a good start. So that's why I asked the question.
we'd be very happy to help support it and spread the word.
That's all I want to ask. Thank you.
Hormones and hormone pregnancy. As you know, one of the things we're looking at is hormone pregnancy tests, and Primodos was the most commonly used, and it contained 10 milligrams of norethistone acetate and 0.2 milligrams of ethinyl estradiol. One tablet taken, another tablet taken 24 hours later. Now, I was reading the PROMISE trial result, which you were an author on, and that demonstrated there were no harmful effects of progesterone for mothers or their babies when used to prevention early miscarriage. Is there any sort of read across from that trial to the hormonal pregnancy tests? Was there anything we could infer from it?
Well, I think the hormone pregnancy test that you're referring to, the Primidos, was pretty archaic. I mean, remember what they did is they gave women, this was before HCG, human chorionic gonadotrophin assays, were freely available, so they would give a woman effectively the contraceptive pill ingredients, and if she wasn't pregnant, then her womb lining would have a burst of hormone, and then it would effectively shed and disintegrate. So if she had a bleed X many days later, they knew she wasn't pregnant, and if she didn't, then they assumed that she was. I mean, it was incredibly primitive. So the progesterone that was used in the PROMISE trial is a different generation of progestogens. But I think it was, I mean, we recruited 1,000 women to that trial over 7 different centres, so it was a pretty extensive, pretty expansive cohort. And I think if there had been if there had been meaningful abnormalities because of progesterone challenge to the fetus, that we would have seen it. I mean, it's interesting, of course, that there's no reason, and my biggest problem with that trial is persuading doctors to stop prescribing progesterone, because it showed unequivocally that it doesn't improve recurrent early miscarriage. So it's
but progesterone therapy is still being used to prevent. Interesting.
Because if you go, if most doctors who see women with miscarriages and repeated miscarriages feel that they need to do something. So it's so it's a bit of a double-edged sword. I mean, so the message that the messaging around that trial should be, it's a complete waste of time and money. We must move on to other things, because we've been using it for nearly 70 years, progesterone in early pregnancy, being proven unequivocally it doesn't improve outcome. However, the message that I think the selective listener has is, well, it doesn't do any harm, so I can hand it out anyway.
Was there ever the science to support that it improved outcome?
No.
So
it was based on the hypothesis that when it was first discovered that you needed a corpus luteum, what was left in the ovary after the egg came out, to produce this hormone progesterone to keep the pregnancy ongoing until the baby placenta had got established and could make its own production. So that was known about in 1953. It was found that was the progesterone was the early pregnancy maintenance. It was just assumed that if you miscarried, that you gave them extra progesterone, that it would sort the problem out. And of course, the hypothesis is completely flawed, because if you're not producing enough progesterone, it's because the messaging between embryo and placenta is wrong, usually because there's a genetic abnormality in the embryo. And if you give progesterone, it's effectively shutting the stable door after the horse has bolted. So it may keep the levels up for a bit longer and prolong a pregnancy which was destined to fail. Sorry.
So would there ever have been a belief back in the 1950s, 60s, that something like a hormonal pregnancy test with a quite large dose of progesterone in it could be beneficial?
I don't know, because I wasn't practicing then. But
I'm sorry, I wasn't inferring at all.
No, I didn't. I wasn't offended.
I think it was before you were born.
Well, Julia, you know my birthday, so that's unfair. So it could have been. It could have been. I mean, it just seems such an extraordinary blunt instrument, doesn't it? That you challenge a woman's womb lining, and if she bleeds, then she hasn't got an ongoing pregnancy, and if she doesn't. And of course, it was hopelessly inaccurate as well.
Yeah, absolutely.
Right. So I'm going to draw this to a close, if that's all right. Just ask my team, anything else you want to ask? No. Anything finally you want to tell us?
Just thank you for conducting the review, and thank you for inviting us.
Well, thank you so much for coming.